Hello, greetings to everybody. We are having our 32nd intergenerational meeting. As you may understand, it's a long way we have been going through. Today, we will be listening to Eugene Koh from Malaysia. Uh,
Okay.
he will be talking on a reflection on self-harm behavior. And our moderator will be Ramin Aprao. I'm leaving the floor to Ramin. Thank you all for being with us.
Okay, thank you very much, Dr. Choshkun, for hosting our meeting as always. So for today, we are going to have a very important reflection on a very interesting topic. So I'm very pleased to introduce our speaker for today. He's Dr. Eugene Koh. He's a psychiatrist and medical lecturer at University Putra Malaysia, who has interest in acceptance and commitment therapy. And an interesting fact about him is he is one of the, I think I can say this, he is one of the pioneers of sports psychiatry in Malaysia, which is in itself a whole different ball game, pun intended. So without further ado, let's have some discussion about self-harm behaviors from Dr. Eugene.
All right, thank you very much, Ramin. So yeah, full context. Today I'm wearing the hat of a therapist more than a sports psychiatrist there. But we had came up with this topic actually because of a workshop that we just organized in our university about 2 weeks ago. And when we were talking about it, we realized some points. So what this workshop was about is we were actually trying to come up with a holistic approach to suicide and self-harm behavior. And what we did was we gathered a group of people to talk about the research updates on suicide and self-harm in Malaysia. And we talk about the pharmacological interventions, the psychopathology, and also various psychotherapy approaches and management towards this kind of behavior. We gathered towards ACT, myself, I did that. We got DBT experts, CBT, psychodynamic, family therapy, and even legal and NGO perspective towards all of this. When we gather all of them and we have a talk, keep in mind that the way this is run is that sometimes as experts, we don't talk to each other. So we actually don't know what the other fields of psychotherapies are doing. We don't quite know what certain other clinicians are doing that well. We know by theory, but we don't actually know in depth in it. And one of the things that came out of that particular workshop was that what we realized was across modalities, across interventions, psychological interventions, and even the pharmacological interventions, was that there was a few common messages or few common ideas that were shared upon. And I felt that that's a nice thing to talk about. That's a nice thing to share about, which I will address. But on the other hand, what that particular workshop also pointed out to us is that these are things that are not shared in traditional education, traditional psychiatry education. And which struck me as something that was rather interesting because here we are training doctors to be not necessarily psychiatrists, future doctors, and yet our education might not really reflect this kind of teaching. So I felt that I was talking to Dr. Bulan about this, and I felt that this might be interesting as a topic to share. But this would only work. I do know we have a few people joining us here. I see at least 3 other students, and of course we have Dr. David and Dr. Bulan with us. And I would like this to be more of a discussion instead of me presenting slides and all this, just to get the ball rolling. But before that, maybe I could just give a full context about what I meant when traditional education. I think most textbooks, and the psychiatrists will agree with me, most textbooks, when we talk about self-harm, when we talk about suicide behaviors, we have a few things in mind. First, we have suicide or completed suicide, which means someone has taken their life. We have suicidal ideations, the idea about thinking about taking their own life or hurting themselves. We have suicidal behaviors or suicidal act or attempt. This pretty much means that someone has attempted to hurt themselves, and if they completed suicide, it's what we talk about completed suicide. And we have self-harm, which means that someone has hurt themselves. And depending on which definition you look at, some say self-harm doesn't have the intention to die. Some say self-harm has the intention to die. Similarly, in some of the literatures, we will have the term that's gaining popularity now is non-suicidal self-injury, NSSI, which is essentially self-harm without the intention to die. Interestingly, despite all of these different terms, one of the things I found very difficult, and I think it's across the board, depends on who you ask. The definitions for some of those terms I just talked about actually varies. For instance, like the self-harm I mentioned, for some it says it must come with the intention to die. And instead, if they don't have an intention to die, why not use non-suicidal self-harm behaviors? Some people, suicidal ideation is a normal thought. Everyone has those thoughts. It's not something we worry and jump about. But for some textbooks, that is something that is considered a risk factor that making someone very likely to hurt or kill or hurt themselves very badly. Some people say the term completed suicide means you completed the act, whereas suicide could also just means attempted suicide, so on and so forth. These terms kind of change interchangeably, and it makes finding information about this quite difficult. One of the things I did during the workshop was to get a research update of Malaysia. And when I typed self-harm, almost most of the research that came out was actually about suicidal attempts, not really self-harm. And a few others. The definition itself is not fixed. So for the interest of today, while sharing, I just keep in mind that I might use these terms interchangeably, but essentially all I'm talking about is just someone who hurts themselves with or without the intention to die. So that's the first thing we've discovered. We discovered the definition was not quite there. The other thing we talked about was that the education about self-harm or suicidal behaviors that's being taught to medical students, I guess, across the world, because most of the textbooks are there. And if you look some of the reviews, we talk about risk factors. We talk about what makes someone more likely to hurt themselves. Common risk factors, substance use, having a severe mental illness, being in certain economic situations. I said certain economic situations because not necessarily being poor means you increase your chance. Certain places being rich or highly educated is actually a risk factor. Being a certain gender, having certain coping mechanisms. We always talk about these risk factors. And in fact, the most common thing that was taught to most students are the sad person skills. Use these skills, and if you find this means that an individual is more likely to have a risk of developing suicidal or self-harm. That's one common way of teaching this particular topic. The second common way, instead, is to talk about precipitating and predisposing factors. Again, using the biopsychosocial model, we say that if someone is in this particular situation, either something that has happened in the past, the predisposing factors, or something that's happening in the current situation, the precipitating factors, this person is more likely to hurt themselves or will likely to continue hurting themselves. These are two common ways we teach students. And from there, when we talk about management, we always talk about risk factors management. We teach medical students this. We teach our medical education teach about, let's manage the risk factors. When you manage the risk factors, someone is less likely going to hurt themselves. Someone is less likely to continue hurting themselves. So for instance, if someone who hurt themselves came in with major depressive disorder, treat the major depressive disorder, the behavior will go away. Someone who has a substance problem, treat the risk factor, treat the substance issue, the behavior will go away. Nothing wrong about all this. I do think that there are literatures, there are research that shows all of this. I think there's nothing wrong with this education. But day in, day out, when we look at clinical pictures, when we see actual patients who presents with this, and they start telling us, I want to hurt myself, and say, okay, you have depression. Let's treat your depression. Okay, you have an unfavorable environment. Let's work on this environment. That's the classical management that a lot of psychiatrists would do when they see this kind of behavior. And that's what the textbook does. That's what a lot of physicians, if you go to the emergency department, I think those what other doctors would do would always do that. But the question then is this enough? Is this sufficient? And this is why I put the title of the topic, A Reflection of Self-Harm Behaviors. It wasn't a novel approach. It wasn't a new approach, because I'm not talking about something new. I think these things has existed and it's there for a reason and it should be there. But interestingly, in that workshop that I talked about earlier, when we ask psychotherapists, when we talk about psychological interventions, when we talk about therapy interventions, almost none of them actually addresses this. Almost none of them actually talk about things like, let's get rid of this risk factor. What we found out was that across different modalities, and these are psychotherapies that range, many decades of, even from DSM-1 on the the psychoanalytic era kind of thing, to CBT, the big big names, to the smaller ones like DBT and ACT. What we found that none of them see self-harm or suicidal behavior as something to get rid of. None of them sees that you have this factor, you have this, let's get rid of it so that you stop doing it. Almost all of them sees it as, it sounds like whatever behavior you're showing here is has a deeper meaning, has a reason behind it. That reason, depending on which modality you're looking at, they will interpret it differently. Some would see it from a behaviorism kind of perspective. Some would see it from a psychoanalytic or psychodynamic perspective. Some would have their own rules on how to actually see it. All of them sees it as, this is just a behavior that represents something. Usually it represents a cry for help. Usually it represents as a need for help. And all of them say, since this is as such, there is a deeper meaning, it's usually called for cry for help. Let's help this individual by providing the help that they need. Let's help them see things differently. Let's help them develop new coping style. Let's help them explore new behaviors, new problem solving, so on and so forth. Almost all the psychological interventions we hear talking through that workshop send this very same message. And a lot of them all says that we are not there to stop you from hurting yourself. We are there to find out why you're hurting yourself, and let's help you from there. And they go on and carry on with that. Interestingly, if we talk about pharmacological, the reverse goes back to the other school of thought. Since you have this risk factor, let's just give you something so that you stop hurting yourself. The whole idea is, let's stop hurting yourself instead of helping the main reasons. So this is where I want to open for discussion, actually, to point out this. Before that, let's classify them first. So the earlier part, I talk about the risk factor reduction, the one that we say we address them, we give medications, we work with reducing all the risk factors so that someone stops hunting. That works more of what we call a universal intervention, meaning that it's kind of interventions that will work regardless where you see the person who's about to self-harm or hurt themselves. It works. It works to a degree. The one I talk about, the psychological interventions, the one where they say that let's look at the individual, let's look at the deeper meaning of this. Those are what we call individualized intervention, because it's you have to kind of individualize it to the person you're seeing instead of a whole general one. I'm going to open with maybe some discussions. Maybe Dr. Barron or Dr. Bulan could chip in then. Why? The first one is, I mean, most of you will be familiar with the universal intervention. Why wasn't the idea of individualized intervention more popular, educated or shown or taught in an equally important manner. Medical students don't learn about this. As such, doctors who come out about this don't know about this. And psychiatrists, if you go into a psychiatry department and you go on to proceed to become a psychiatrist, you might learn more of this in depth. But at least in Malaysia, the psychiatrists themselves also might not know so much about this kind of individualized treatment. So yeah, I just want to open this for discussion. Then, any opinions, any thoughts from the floor? Dave, you're muted.
I said, as my longtime mentee, who I'm very proud of, I want to share something that I want us to discuss. And that's most people go into medicine to save lives. So when a patient wants to end their life, for many, and this has been well documented over the years, it's like a defeat. They're working, it's like a tug of war. We want to keep them alive. And when they want to end their life, if we look at our colleagues, they get very disgusted when a patient wants to take their own life. If you look at emergency room docs, they'll say, just let them go die. I'm here to save the people who want to be saved. So our indoctrination is really one to save lives. And then when we look at suicidality, and Eugene, an excellent point, the biopsychosocial, spiritual, religious, virtually every religion in the world says to take one's own life is committing yourself to a life of purgatory or hell. I mean, I don't know any religion that endorses taking life. However, culturally, if we look at the Japanese culture, and this was a big issue about 20 years ago, I was doing a little work in Japan. They talked about an honor death. So the whole kamikaze. In fact, I want to share a real brief story. I had a 28-year-old woman a number of years ago when I was at LA. She had 3 young children. She was from Japan. Her husband was an executive with Toyota. She comes over to LA to follow him. Long story short, he ends up having an affair. She did the company, got fired. She takes the 3 kids. They go out into Santa Monica Bay to kill herself and her 3 kids because it was an honor death, that she had been dishonored. So tragically, what happens? The 3 kids die and she survives. And I was on the consult service, so they asked me to evaluate her and whether she was going to go to jail. And this woman, by no means, she loved her kids, but she felt dishonored. So I think the key to this is to understand the complexity of suicide. For many suicidal patients, and I want to have Boulant mention this, actually, the self-harm is to not kill themselves. I started my career as a psycho-oncologist, and patients say, no, death is the only relief I have of the pain. So when we say it's self-harm, from their perspective, oftentimes, no. Self-harm is to continue to live. And I had a psychologist who I was treating at terminal cancer, and I was seeing him as a young psycho-oncologist. And he was kind of dealing with some issues with the ending of his life. And he had a daughter who was in college who was very proud of. And I remember I went in to see him on a Friday, and he was the least depressed I'd ever seen him. I've been seeing him every day on the consult service. But I was really worried that he had gotten this flight into health. I went back to see him on Monday. I said, Joe, obviously not his real name, you really had me worried. And he looked at me and he said, you knew all along, didn't you? I said, knew what? He said, you knew I was planning to kill myself for the week. I had no idea. He said, you knew I'd been cheeking my pills and I kept enough medicine. And he said, I really appreciated you not pushing me on this. Couldn't have been further from the truth. I just knew something wasn't right. And I said, well, Joe, I'm really thrilled. But tell me, explain to me what happened. He said, the pain's getting worse. I know that I only have a few weeks, maybe a month to live. And the pain keeps getting worse and worse. And now I'm losing control of bodily functions. And he said, I just wanted to go out with some dignity on my own terms. And he said, I called my daughter Friday night and I wanted to say goodbye to her without telling her what was going on, but just to say goodbye from college. And he said, I got her on the phone and she said, hello, Daddy. And he said, I started to cry and I hung up the phone. And I said, Joe, what was going through your mind? He said, when she said, hello, Daddy, the thought that went through my head is if I kill myself, my final message to her is not goodbye, but it's if life gets tough, check out. And I can't leave her with that message. that you got to fight through it. So I think when we talk about suicide, it becomes so complex. There's the cultural piece of it. And we do a very lousy job of teaching medical students. It's just not a topic that I don't think we as professionals feel particularly comfortable with. Do we present it from a cultural perspective? Is it really an honorable death? Well, that's a big campaign we did in Japan. No, there's nothing honorable about killing yourself. This had historical importance. The religious perspective, as you know, Eugene and I do a lot in sports. One of the things we see suicide in is a certain percentage of patients with chronic concussions. And it turns out that what they do is they get very impulsive. So suicide can be an impulsive act. It can be a very angry act. My girlfriend or boyfriend of 6 weeks will be really sad when I'm not here anymore. So, we see these, it's such a complex, and we use and we try to, put a label on it. I mean, suicide isn't a diagnosis, as Eugene said. So I think it's really, the important thing is to discuss this on why we don't feel comfortable in general talking about it and what can we do. Because if you look at the AFSP literature, and you look at what's been done in this area, Maria Kindo from University of Pennsylvania, suicide expert, Charlie Nemroff, suicide expert, it's really what we tend to see in many of these is the psychic and the physical pain that they just see no way out of. The ultimate hopeless is helpless. This is the only real solution. It's not self-harm, it's self-revelation and this incredible sense of feeling alone and isolated. So with probably the most successful adolescent suicide program ever developed was a program called Amico Charlie. And it was set up, it was all peer-based. It wasn't psychiatry-based, psychology-based, but it was getting adolescents to feel reconnected, that I'm not in this alone. I can talk to somebody else. A lot of the internet bullying that has led to some pretty aggressive self-acting out. When people say, no, I'm not alone. I've not embarrassed myself. It goes back to that cultural thing. So this is what I think we could have a very rich discussion tonight, talking about the complexities and what can and should be our role as consultants to our colleagues or dealing with our patients. And Eugene, I think you really set the stage lovely.
Yeah, I fully agree. And one of the phrase we use in at least when I was teaching my therapy is we sometimes would point out something to the patients, the clients. When I say this, I don't mean to encourage someone, by the way, just keep that in mind. Suicide is a very effective problem-solving behavior or skill that comes at a great cost and is highly irreversible. When we say this, when we teach and we talk about this idea, it's to point out that it actually is a kind of behavior that's rather useful to get away from something that's very painful. And this is what we often see in a lot of our patients. No, very rare. In fact, I've never heard of it. I'm just going to use rarely here to cover all bases, but we don't hear patients say, I intentionally want to die or hurt myself. Full stop. It's never that. It's always, I want to try and hurt myself because, and then whatever that comes tends to be a situation that is extremely painful and they have no other solution at that point. Very often when we work with our patients and we say that, what if we can work out an alternative? What if you could make your physical or psychological pain lessen or go away or bearable? Nobody wants to choose suicide or self-harm as a choice anymore.
Exactly. And Tim Beck talked a lot about that.
Yeah. And so this is important. And I agree with what Dave says also, this we are horrible in teaching students about this idea, because this idea, I wish it was taught to me in my medical school. I learned about this 10 years ago after, on my way to become a psychiatrist. That was the first few times I started hearing. Even in my early stages in my specialized training, that's all we were taught. Look at risk factors, look at this, solve this problem for these patients. Don't make them die, because as doctors, you're supposed to save life. Don't let them die. But we miss out the whole entire fact that it's so much more complex and there's so much more behind it. And this is where I want to share. This is where also I hope with this particular session today is that I hope that this awareness could come out, with that educators know about this, that we talk more about these kind of things. In a way also, I feel that if we have taught medical students at an early stage to look at it in this way, to look at suicide and self-harm behaviors in such manner that it's more complex, that it's often coupled with different ideas behind it, imagine the kind of doctors that we're going to produce who's going to run the ER the next time. These are not the ones who say that you are a burden. These are the ones that would probably be more empathetic and go on to ask, what make you want to do this? Instead of waiting for the site evaluation to come in and then ask that same question. At the early stages, all of this could have been done, but we found it very interesting that, you know, this is a missing piece in a lot of medical education across the world, not just Malaysia. I'm not sure why. Again, maybe because it's a very complex thing. We don't want to confuse people more than that. But the whole simple idea could actually be conveyed to a degree. Yeah. Maybe I just open up to the floor again. Anyone else have other opinions or want to chip in? Or no. All right. So yeah. So this is something I just thought I want to reflect upon. Personally, I've done both in my as an educator. At least for my postgraduate students, my undergrad students, I don't get much time with them. I might not talk about this too much, but I usually teach them two things. I would tell them about the textbook because that's what they need to pass exams. They can't go into an exam and tell a random examiner to say that, yeah, this person want to hurt themselves. I want to sit them down and have a cup of coffee to find out more about them. They probably will fail their exams because that's not how the exam are formatted. But I will also try to preach this kind of message to tell them that aside from knowing all these risk factors, it's always good to kind of explore more, to find out more what actually is the driven behavior behind it. And sometimes pause to consider, instead of trying to stop that particular behavior, find out why it's happening and see what you could address about it, what you could do about it. And from there, you probably could help the patient even more. That's just one. Yeah. Bullet.
Thank you very much for all those things. Thank you, and David. I would suggest talking about death in general, death and dying, before talking about suicide. I remember my own studentship. I was a medical student when one day one of our elder persons, a resident in psychiatry, came to our seminar, and he said he had a topic to discuss with us, but he said instead of talking about this, I don't remember what that topic was, let's talk about death. I was very much impressed with that. And that indeed changed many things in my life. That was the first time I heard about Kübler-Ross. And I tried to, I thought of translating that, her book, but I couldn't manage to finish it. Anyway, before suicide, I think we should consider talking about death itself. Would you allow me to ask our younger colleagues what they think about death and dying, and how much that issue is in their medical education?
Well, perhaps I can offer some an opinion of mine. Early on in my life, that I have experienced many deaths within my family, including the death of my father when I was 14 years old. So when I decided I wanted to become a doctor, all I could think about was exactly like what Professor Barron said. I want to be a doctor to save lives. So in the early years of my medical school, that's the mindset that I had at the back of my mind. But there came a time, I think it was probably in my third year, when we had a rotation at the palliative medicine department. So that's when I learned that sometimes death is not always a bad thing. And it's something that we all will go through, at least with the technology that we have now. No one can stay immortal. So it is something that we all have to face eventually. Um, and thus, I think that is something that we should be aware of, but not, uh, I don't know, maybe if you're a religious person, it may be something you look forward to, because in a sense, it might be, a paradise, or, depending on your belief. Uh, but even so, if you're a non-believer, you're returning to the dust from which you came, you know. So either way, I think it's something for us to be aware of, and more important, more importantly, being aware of that can help us prepare ourselves and live our life to the fullest, I suppose. So that palliative medicine posting actually shifted my paradigm, and made me understand that from a different perspective, and I still hold that new perspective till today.
I would agree with that. That is probably the biggest lesson a medical student or anyone could learn in their education years. I didn't know this last time. Was that as doctors, we are not omnipotent. We're not gods. We cannot save everyone. And sometimes death essentially is a positive thing. It's a good thing also. And this is something that if having that knowledge, idea, being comfortable, again, I'm not encouraging embracing death. What I meant is that being able to see death not always as a bad thing has its uses, allows us to figure out when and how we should help. Do we want to prolong life? Do we want to extend life? Or do we want to make them comfortable, at peace? And even certain life medical decisions that are pretty much either do you pull the plug or do you keep on the plug? Having an appreciation of death, having an appreciation of dying, having an appreciation of the way I look at it, having an appreciation of what it means to have a satisfying life. All of that would be a very useful idea. And when you are comfortable with all that, you can make better decisions as a doctor. I'm not even talking about as a psychiatrist, as a doctor. I think, Ramin, you're one of the few batches that I started talking about this particular topic also, right, on death. So this wasn't a topic that was even in our undergrad syllabus. I only start talking about it about 4 or 5 years ago only. Students appreciate it. They actually realize that when we can talk about this in a more wholesome or holistic view, it allows them to become a better doctor later.
I think an appreciation of how context dependent it is. Whether you're a young person, your views of death, if when you're 90, might be hopefully different than when you're 9. And that it's not a fixed thing. That Freud said that that we didn't really have the capacity to understand death unless it was. He talked about a mother, the death of the child. That was whether that's true or not. That was the Freudian concept. But I think what is important is our concept of it and how we think and feel about it, and then maybe ultimately behave, is incredibly context dependent. Whether we're in the position of being a treating physician on an oncology unit with a patient who's suffering and we have no real answers to it, or it's our own parent or grandparent or child, we might want to say, no, we're going to fight no matter what, just keep them alive, and then it's like, is existing the same as life? So I think understanding and being able to deal with, and I want to get back to what Professor Koshin said to our students and our young people on here, the context of where we are in life will oftentimes affect how we feel. We wear the hat as a clinician, as a physician, as a psychiatrist, but we also dealing with our own issues of mortality of our loved ones, and how it changes. You know, you go for your routine physical and someone says, oh, you have a lump, and the next thing you find out, you've got metastatic cancer and you've got six months to live. Your concept of death will certainly be different than, you know, you've got everyone in your family lived to be 100 years old and you're only a mere 75. So you figure you've got at least 25 years left. So I think understanding the context of how it presents, and we bring our own personal experiences, what we've been taught, what we've experienced. But I want to get back to what Professor Koshin said. I'd love to hear, what are the thoughts of our younger members on the call tonight? What are your thoughts about this? Because you're in those developmental stage as a physician, and how that will affect how you choose to act when this thing comes up that we're not particularly well trained in, because doctors aren't trained to deal with death. We're really trained to deal with life. Not that we should be, but that's pretty much the way it's been for a very long time.
Hello. I got some idea about that. Just because I'm teenage still, in a part of way. I deny of that concept for a while. So I got a motto, maybe. I live until I die. So I'm just living my days. It's not a good way, probably. But for now, I got this idea. Also, something about suicide. What can I say? For our patients in the future, I want to talk with them and the way of why they act like this. And I got some books about the suicides, because in this year it's very popular idea, unfortunately. So when I when I read them, I decide that it's something about loneliness, just being alone, and I think we should solve this problem. That's all.
I think my talk has already been successful just by hearing one student say that I want to ask more about it. We definitely, the whole message is sent across already. I'm more than happy. What about the others? Anyone wants to chip in or kind of comment about what we've been discussing so far? This is a bit different. I did not come prepared with any slides. I just want to throw this idea out, both what Bulan said and what I said earlier. And in fact, I said I would agree with what Bulan mentioned, because if you have an appreciation of death, then you wouldn't try so hard to prevent someone of wanting to embrace it so quickly. Instead, you want to find out why and could do something. So I do agree that having a concept to actually explore, understand our own conceptions of death and dying would also impact some of the things that we've been talking about. Maybe could we hear from at least one more other student on the perspective that what we've been discussing?
Let's ask the students, should we be teaching more about this? And if so, what should we be teaching? I mean, you're in the middle of this. You know, how can you help us as educators? You know, should we just forget this? Should we have formal lectures? Should there be discussion groups? What would be the most effective way to help you become the best doctor you're going to be able to be, taking care of patients regardless of your specialty moving forward? How can you help us do a better job as educators?
Discussion
So,
group. Perfect, I think. I'm sorry,
yeah. So, sorry, I'm on my way to the clinic, so I can't really open my camera, but I want to say a couple of things. First of all, in the topic of suicide, I really think that we shouldn't be marginalizing suicide that much, because maybe I got too affected by the really bad prognosis patients. Like in this clinic that I'm working in currently, there are patients that have neurology problems and plus psychiatric problems. Like lots of somatization disorders plus chronic pain, blah blah, and maybe tinnitus too. Like these patients can't even talk without getting angry or aggressive. But when I think about those patients, like they think that their issue is unsolvable, and doctors are kind of feeling like that too. They wanna decrease their pain, but in with the science in our hands, it's not like fully possible. And plus, as you all said, we're all gonna die in yeah, we have to die. But the I do not know how to draw the line. Where to draw the line actually, as a medical student or a person too. Like in my own personal life, I'm not fully decided where to put suicide as a philosophy or a I don't know. But when it comes to the thing that people are committing suicide, most of the patients are committing suicide because they have pain or they need help. If there's anything that we can do as doctors, yeah, of course we should do. We should help those patients. But there are patients that I think we can't really help too, like as maybe some cancer patients, etc.
I could relate to that actually. So when I was a medical student, I used to work with hospice, and I remember I couldn't sleep with the first hospice patient I was talking to because he was about my age and he knows he was going to die. And I remember losing sleep about it, wondering what else could we do? Why couldn't we extend his life and all that? This was when I was in the early stages of medical school. But in reflection now, that conversation I had with him at that time was that he wasn't going on and on about I want my pain, I don't want to die. He was talking about how he could spend his last days meaningfully and pain-free, in fact. And those were the things that was going to impact him. Those were the things that was going to be useful to him. And I think that's what I think that's very, you are correct there. I think being exposed, being aware of all this, being aware about how pain could impact someone's decision, how pain could impact someone's idea about death and dying. And pain here, I don't mean just physical pain, even psychological pain. Being aware of that and asking the one question is, what could I do about this? What should I do? If I don't have choice, what else do I have? Just by asking those questions, it will set you all on a better path in the future, because then now you're not going to just go in and say, I want to solve the problem. I want to solve this. I want to solve that. You don't close yourself up to all those options. Instead of, I see this now. What other options do I have that I can work with the patient? Just by having that question to ask, what else can I do? I think that itself, it's already a very good approach. And I do think that's a great idea. Medical students should be exposed to this straight away. Send them and see, a dying patient, or have them to talk with someone, maybe even someone who's suicidal, so that they could understand, so that they could start asking the question, what else could I do? Instead of just a simple, see these problems of this medical intervention. At least there's a pause there, and then at least there's room for alternative discussions or options. What about the rest? Anyone else, or what to comment or talk about it?
I think Mevla was typing something.
Yeah, Mevla?
I agree with Dilara. People are so lonely, I think, nowadays, and they can't talk each other. So it's very really bad for them. I think we should each other, and as psychiatrists or doctors, or who wants to be psychiatrists and doctors, um, they have to listen people and solve them problems with them. I think we should each other, and we can't be lonely.
Well, you're 100% correct. So the U.S. Surgeon General came out a few months ago, and said that probably the number one public health, not mental health, but public health crisis in the United States was loneliness. And I think we could probably take that, we know what people went through post-COVID when people were isolated. And even though they could get on Zoom calls, they felt very lonely. My wife's a high school coach, and she talked about how her team, they couldn't, when they finally got together and see each other, they were so thrilled to give each other a hug. So you're 100% correct. Loneliness is a significant global health risk. And we need to, as psychiatrists, certainly, but all physicians, it shouldn't just be psychiatrists. I think primary care physicians should be asking our patients, do they feel lonely? Do they feel connected? Because it's not just their mental health, it's their physical health. And there's robust data to demonstrate that that's a fact. That's not just a fantasy.
Loneliness do after all lead to pain also. It is a form of pain.
Some say maybe the ultimate pain. What do we do to punish our most severe criminals? We put them in solitary confinement.
That is true. That is
ultimate
true.
punishment for most people. If you're schizoid or maybe something else, but let's, for the vast majority of the world, feeling lonely, feeling isolated, it's not only the psychic pain, but it leads to significant physical pain and physical pathology.
Yeah, I mean, even if we go along that line, even if we talk about certain neurodevelopmental conditions, autism, who has difficulty socializing, most of the time, the adults who are functional comes to see us because they are lonely. They have difficulty socializing, but they want to socialize. They don't want to be lonely. It's a very human thing to experience, I guess. All right. I think, yeah, go ahead.
Maybe loneliness itself or being lonely could be another topic which we can discuss here. Because that is indeed what people understand from being lonely. You don't have to be isolated, or as most poems or writers say, poets, I should have said, you can be lonely among the crowd. And what we understand from loneliness, similar to what we understand from death and dying, that David has put it into a context. That is indeed, the context is important. And yeah, these I think is the feeling of loneliness did not start from having these Zoom activities. We always feel lonely, but how do we talk about it? And there was one other thing which Mevla mentioned, listening. We all recall Dr. Sartorius always underlined the importance of listening. That's important in teaching medical students about psychosocial approach. We were talking with Ramin why we have reduced interest from medical students to our seed activities. Maybe we can't understand what they are searching for. And we should listen to their thoughts. But of course, to be able to listen, we have to see them or hear them on writing. That's something which we miss as well. Anyway, I have carried along the topic. I want to underline the importance of what we understand from loneliness, similar to death and dying, and of course, listening and how we listen.
Yeah. So I think time is almost up. I could just wrap up. Just to go back to the original topic, I mean, we've gone through things. We covered different perspective about this whole idea. There was one more message in the workshop that we found that was being sent across all psychological interventions, which I did not point out to. And it goes back to some of the opinions that I was talking about here. We talk about how self-harm and suicidal is a behavior that has deeper meaning behind it, that is worthwhile to look at it, to ask about it. But one of the things I noticed across all the other psychological interventions is that they also promote something called hope. None of them goes on to say that let's help you get out of, let's help you solve this problem. A lot of them instead works on this idea: we hear you, your behavior here is a message. Let's find ways. I remain hopeful that we could help you find hope again, to help you find ways that is to bring hope back into your life, to help you again with this pain, or at least the hope that this pain will be. And this was something I find interestingly was being promoted across different psychological intervention that, of various ages. This is something they have always been talking about from the initial ideas of modern psychotherapies until now, that all of them will promote this one same idea: hope. And this is a bit different from the universal intervention that we talk about, which is let's solve your problem. Let's get rid of something. Psychological interventions don't do that. They said, let's help you find hope again. And I think that would be just my last point to highlight, again, to summarize everything that we talk about. So with that, thank you again for joining us this session. Ramin, I'll hand it back to you for the closing.
Thank you very much, Dr. Eugene, for facilitating our discussion today on self-harm behaviors or suicidal behaviors. I think we can all go back to our respective practices or future practices and keep this in mind and reflect on death and these behaviors when we are seeing our patients, and always bear in mind to ask more and have a more holistic approach towards each individual whom we meet. So with that, thank you very much to all those who have joined our Zoom call, and also those who may be watching on YouTube. I'm not sure if there are any, but if you are, thank you. And we will meet again next month. Thank you very much, everyone.